Good evening. My name is James Relle. I'm a urologist at Michigan Institute of Urology. I have a number of special interests within urology. Prostate cancer surgery is one of them, specifically robotic surgery. And as a result of working with prostate cancer patients, we also have the secondary issues of side effects from surgeries, both those done in our own offices as well as those done elsewhere, that we're faced with managing. Today's discussion will focus around the issue relating to urinary control, typically following prostate surgery, but also from a more global standpoint, urinary incontinence in men. And I'm happy to field questions at the end of the discussion. And along the way, if there's anything that's unclear, please feel free to stop me. As far as this series of discussion, this is relating to survivorship of prostate cancer and survivorship patients. We hope that the information you get here is of use to you. It doesn't replace a regular office visit. It doesn't replace the regular relationship that you have with your acting physician. But what we hope to do in this is to expand your body of knowledge so that you can ask educated questions with your doctor if you're unhappy with the process that you're going through. With regards to urinary incontinence, think of the urinary system as having two main components. It has a reservoir, which is the bladder that stores urine 99% of the time, and a piping system that allows that urine to drain out the 1% of the time that the bladder is emptying. Those are the only two processes that the urinary system has, storage and emptying. And urinary incontinence is when the urinary system fails to maintain the control or the storage capability that it is supposed to have. Usually this is related to a valve issue. The bladder has an outlet that is controlled by an on-off valve, essentially. That's called the urinary sphincter. And when that sphincter is damaged by a variety of processes, and in this particular setting typically related to prostate surgery, then the control of storage is damaged and urine leaks out. There's essentially three main kinds of incontinence. The most common kind relating to prostate surgery is stress urinary incontinence. Stress urinary incontinence doesn't mean that you're stressed about it, although it can. What it means is that when your abdomen is under any kind of stress or increased pressure, the pressure that your abdomen creates will overcome the resistance of the control valve, and the result will be leakage. It's not much different than when you have the Heinz ketchup open over your hot dog and nothing's coming out. If you stress the bottle by hitting it with the palm of your hand, that's creating pressure, and that will expel ketchup all over the place. Stress urinary incontinence is very similar in concept to that. Urgency incontinence is a different kind of incontinence. In urgency incontinence, you feel the urge or the need to urinate, yet you can't get to the bathroom in time. You can't control that bladder contraction that's happening. Oftentimes the contraction should not be happening in the first place, and we can go into why that might be the case. But urgency incontinence is not related to the valve as much as it is to an overactivity or hyperactivity of the muscle that's creating emptying, in other words, the bladder. The final kind of incontinence that we see is overflow incontinence. Overflow incontinence is a paradoxical situation. It's when the bladder is actually not emptying properly and it's overfilled. And it's no different than a cup of coffee that you keep adding coffee to. Eventually it'll get to the brim, and then if you keep adding coffee to it, it'll overflow and it'll leak all over the counter. It doesn't mean that there's a hole in the cup. It just means that there's too much for the storage capacity and it gets overwhelmed. So those are the three main kinds of incontinence. So what causes these? Well, a variety of factors will cause any one of these different kinds of incontinence. As we talked about earlier, surgery, specifically prostate radical surgery, where the anatomy is disrupted based on purposeful surgical removal of the prostate, but also in the more traditional benign operations for the prostate, such as the scraping procedures called the TURP, also affectionately known as the Roto-Rooter. Those operations can ultimately damage the control valve as well. Other conditions like diabetes, which affects small nerves and blood vessels, will damage the bladder function and bladder sensation abilities. Neurologic conditions like multiple sclerosis or Parkinson's disease will have a significant impact on the nerve functionality of the bladder. And then other things like pelvic trauma or major blunt force injuries, surgical misadventures from other operations, birth defects or things that people were born with from a spine functionality standpoint. These will all contribute to urinary incontinence. There have been thousands of studies done on the impact of incontinence. Suffice it to say that the usual inconveniences of laundry, odor, skin irritation, expense, these are major motivating factors to get rid of the problem, both from our end as surgeons and healthcare providers, as well as from a patient standpoint. There are a variety of treatment options. Some are treatment and some are actually control or Band-Aid type problems. Absorbent products would be an example of a containment issue as opposed to fixing the problem. But most patients start off with absorbent products as their first line of defense and pretty quickly find that they're not satisfied with that. But in very minor incontinences, situations where, for instance, patient will only leak if he does a very vigorous, sudden form of exercise like a serve in tennis or tossing the bowling ball down the course or something that requires a single sudden impact. Patients may be actually okay with using a absorbent product temporarily around the time of planned physical activity. Those patients who are suffering to the degree where they need to wear this constantly in order to protect their clothing are obviously not going to be satisfied with that options. Internal collection devices, these are devices that essentially will contain urine but not actually prevent it from leaking. An example would be something like a condom catheter or a catheter that goes directly into the penis known as a Foley catheter. And external devices which similarly will collect it the same way. These are essentially methods of controlling the leakage as opposed to fixing the problem. But they do work very well in the right situations, and so they're part of the armamentarium that we have to combat this issue. Collagen injections are methods that work quite well in female patients, less successfully in male patients, especially after radical prostate surgery. But these are adjuncts that can add bulk to the urethra and improve urinary control. And finally, there are surgical options which can help patients manage urinary control, and I'll try and focus on those as we go through our discussion. As far as medication goes, for the treatment of stress incontinence, there's actually no FDA-approved medicine for this particular purpose. The reason is that it's very hard to get a medicine developed that will sufficiently constrict the specific isolated control valve mechanism, which is already damaged to a degree, so it's even harder to get something to work that's damaged. But to get a medicine that also doesn't affect other things like the heart or circulatory system is extremely difficult. We haven't found an appropriate medication. But medicine does work for urgency incontinence. So for patients who have irritative symptoms of frequency and urgency and not getting to the bathroom in time, medication is actually typically the first line of attack for those patients. The absorbent products that we talked about, pads and diapers, these are very useful in the right setting. The major problem, quite honestly, is first of all, there's just the embarrassment of having to go and shop for them. But with online shopping, that at least is mitigated to a degree. But the cost is overwhelming. I mean, it's hundreds of dollars a month and thousands of dollars a year when you translate that for the majority of patients. And then the added problem with diapers and absorbent products is that they don't do a perfect job. They do a decent job. And anyone who remembers changing their baby's diapers, the constant moisture against the skin will lead to skin breakdown and damage. So it's considered a temporary type measure, one that we don't particularly want to continue using long term. There are containment devices such as a clamp. Cunningham clamp is the most commonly used device like this. These are devices that essentially add resistance to the urethra, which is the tube that one urinates through. They're essentially going to squeeze it shut. It does it in a way that's somewhat protective of the normal anatomy. It's a heavily padded, spring-loaded mechanism that can essentially sandwich the urethra between two sponges. This will be at least not painful. It may not be the most comfortable thing, but it does add a degree of resistance that is, in many cases, adequate to stop the leakage and avoid diapers altogether. So some patients wear this, for instance, if they're going to play tennis, and that's the only time that they leak, they'll put on a clamp, do their tennis, discreetly take it off in the change room and be done with the problem. But again, it's a temporary fix and not a true fix of the problem. As we talked about earlier, there's various forms of catheters, both condom and indwelling catheters, that essentially drain the urine away from diapers or clothing and into a closed, contained environment. That will, in many cases, help with the odor because the vinyl bags that they're in are generally fairly insulating as far as the smell goes, and also by way of draining every 3 hours, just like you would normally go to the bathroom. Draining these collection devices will eliminate the issue of odor as well. Urethral injections I touched on earlier. In women, these are generally quite successful. The female anatomy is much more flexible and easy to inject. A bulking agent literally will swell up the urethral tubing system so that the actual surface area of the tube is much reduced. It's like putting your finger over a garden hose. It blocks flow. In men, for some reason, it's been very, very unsatisfactory. Particularly in male patients after radical prostatectomy, because the tissue and the area where we would normally be injecting this, right around the control valve, is already scarred and damaged. And so there isn't a soft and distendable area where when you inject the material, it will sort of swell the urethra up. It tends to be a very unsuccessful procedure, but in some cases it's worth trying. And until probably about 5 to 10 years ago, when the other alternatives that I'm going to talk about in a moment were not readily available, this was the preferred first-line method of trying to manage prostate-related incontinence. The success rate is somewhere between 10 and 20%. It's not great. So basically, 8 out of 10 patients will be unsuccessful with this. Surgical options tend to be the most satisfactory. The downside of surgical option is that the majority of the patients who we're recommending these to are just coming off of or have had relatively recently some kind of prostate major surgery, and they're not particularly chomping at the bit to have yet another surgery. The upside of the surgeries is that they're very, very effective. And if a patient is unhappy with his degree of urinary control, we can offer somewhere between 90 and 97% success rate in improvement or resolution of the control issue with one of 2 surgical interventions. Surgical intervention number 1 is the male sling procedure. The male sling procedure evolved after the success of women with sling procedures. In women, it's in a high 90% success rate when used properly. It's a very, very effective, very low risk, and very long-term management option. A few very genius-like investigators tried to figure out a way to apply the same principles to the male anatomy and developed a transobturator technique, which essentially uses a mesh in the same way that we use that we place the women's mesh, which is from one groin through a bony opening in the pelvis, under the urethra, back through that bony prominence and out the other groin, and then we trim off the mesh at the skin level. So everything is internalized and done through a relatively small incision in the perineum, which is the area behind the scrotum, which is essentially invisible to pretty much anybody. The sling is used in general for mild to moderate incontinence. Mild to moderate incontinence is defined as either no or one pad a day would be considered mild incontinence, where someone is most of the time fully under control and not leaking, but in periods of stress or exertion, we'll find that they leak a couple of drops. Moderate is obviously a little bit worse than that, but not requiring constant use of pads and not requiring changes of soaking wet diapers. It is highly, highly effective. It's an outpatient procedure. It can be performed under both spinal or general anesthetic. The recovery is very quick. If I do a patient on a Friday afternoon, they're back at work on Monday. It's very well tolerated. In the vast majority of cases, a catheter is not required postoperatively. We always place one intraoperatively to protect the urethra and identify the anatomy, but the catheter is removed at the end of the surgery, and in over 90% of the patients, they're able to urinate, and they're able to urinate adequately. What patients often do notice is that they will have a slower stream than they did prior to the surgery, and that's because we are adding a substantial amount of resistance to the urethra. And what we're essentially doing with this procedure is we're taking the urethra and pulling it back into the pelvis into its more normal anatomy, where the hammock of pelvic musculature can actually have the desired and normal effect on the urethra, which is to keep it under normal circumstances closed and shut under stress. There is no need to activate or turn anything on or off. There's no need to monitor anything about this once it's put in. It's generally a one-shot, one-procedure technique. And the other benefit is that if it turns out not to be enough and you require the other kind of surgery that we'll talk about in a moment, the two surgeries are done in slightly different locations, and one doesn't compromise the other's opportunity. So if you have a sling and it's not enough, or things get worse down the road, you can still have the artificial sphincter. So I use the male sling very often because, in my experience, the vast majority of patients who have incontinence have it relatively mild. And for those patients, if they're truly bothered by it, then there's a fix that is highly effective. This is not for patients who have regular urinary tract infections, who have bleeding disorders, who have immune status deficiencies where they can't fight off infections, where they have kidney insufficiency, or where they have actual bladder outlet obstruction or bladder dysfunction. But it is for patients who have a specific deficiency of the muscle of control, because that's what this addresses. Artificial urinary sphincter is the gold standard of urinary control surgeries. The concept of the artificial sphincter is that it has an inflatable cuff. If you think of the floaties that kids have for learning how to swim, the cuff is the equivalent of the floaty around the kid's arm, and the urethra would be the equivalent of the arm. So the inflated cuff, under normal circumstances, is filled up with fluid and compressing or squeezing shut the urethra. When a patient wants to urinate, there is a component that is hidden in the scrotum or the sac that allows transfer of fluid from the cuff to a balloon which is shriveled up in the lower part of the abdomen and also hidden. And when you squeeze the pump in the scrotum, it transfers fluid from the full cuff in the urethra to the empty reservoir in the abdomen. That allows the urethra to be free of resistance. Patient then urinates normally. And then over the next 2 minutes, the reservoir that is now full has enough pressure in it that it will flow backwards back into the cuff and refill the cuff. So the natural default of this system is that the cuff is always inflated unless you voluntarily deflate it. So what that means is that the 99% of the time that you need the cuff inflated, it's inflated. And when you need to urinate, you deflate it. And then it will do its own thing and fill itself back up. The diagram here basically sums it all up. Empty balloon reservoir, which is hidden underneath the skin and not visible. A pump in the scrotum, and a cuff around the urethra. The bladder fills naturally over time. The urethra is occluded by this cuff, and when you want to urinate, you'll squeeze the cuff. The fluid gets transferred from the cuff to the balloon. The pump will allow that to happen. Urine will be able to flow out, and then the fluid will recycle back into the cuff. As we said before, this is the gold standard. It too is an outpatient procedure, although many times, depending on the time of the day, we will elect, or a patient will elect, to stay in overnight just for observation. We often temporarily leave a catheter in overnight, and for that reason, even though it's considered an outpatient procedure, the overnight stay is an insurance term that allows us to keep a patient in overnight, but as long as they don't stay in 24 hours, it's considered an outpatient procedure. So we get the best of both worlds, ensuring that the patient doesn't have any complications from the procedure, ensuring that the patient is able to urinate spontaneously after the catheter is removed, and then the patient gets sent home. Over 90% of the patients who've been surveyed who have had the cuff placed would have it placed again if given the opportunity to. The reason is that it's so successful, and for patients who need the cuff, their incontinence is so debilitating and so unpleasant that having the cuff, which cures the problem in over 90% of the cases, is a godsend for them. So it's an excellent, excellent option. It is bigger surgery, just because we have to make an extra couple of smaller incisions. It is bigger surgery than the sling procedure, but again, it is designed for a more extreme problem, and so you need a more invasive procedure to do that. All of the components of this operation are all buried and hidden. So from a for patients who are shy and who don't want to be seen with paraphernalia, this is it's an excellent procedure because there's nothing visible to anyone. In fact, in some cases, patients who have a new partner who was not aware that the patient ever had this operation would not even necessarily notice that they have this system and that they're working with an artificial pump. Once again, there are limitations as to who we can put this in. The same patients who are not good candidates for the sling are also not good candidates for this. One of the wild cards in all this is prior radiation therapy. We always wrestle with patients who've had both prostate surgery and subsequent radiation to control their cancer, because radiation has intrinsic to its functionality an effect of damaging blood supply to tissues. It renders it relatively ischemic. And when tissues are ischemic, it means that they're not healthy, they don't heal well, and they're prone to break down over time. So placement of either a sling or an artificial sphincter is potentially fraught with a complication because of the effect that radiation has on the surrounding tissues. It doesn't happen in everyone, but it can be a pretty dramatic event when it happens. So we have to think long and hard about doing these invasive procedures on prior radiation patients. I'd certainly be happy at this point in time to field any questions that you have relating to this or prostate cancer in general. So the question is, we're well aware of the success of the artificial sphincter, but we'd like to know what are the long-term complications and breakdown issues with the technology. Artificial sphincters have been around for upwards of 30 years now. It's a tried and true technology. It's actually very simple. It's essentially one valve and a pump that transfers fluid from one unit to another. The materials are generally very high-grade materials that don't leak. But with anything with moving parts, there is a breakdown rate. We jokingly refer to our patients that they have a 10-year warranty. There isn't specifically a manufacturer's warranty, but on average, these things will work flawlessly for 10 years without need for any kind of intervention or change. And the components can be swapped out if they break down over time. There are certain issues that have to be carefully considered with an artificial sphincter. If a catheter ever has to be placed in a patient with an artificial sphincter, let's say a patient's going for hip surgery and they're going to place a catheter prior to that, it's extremely important, and we in-service patients who have these sphincters carefully to advise them of this, but it's very important that the sphincter be deactivated, meaning that the cuff be deflated, all the fluids in the reservoir, and it be locked open like that for the duration of the time that they're going to be catheterized and require any chance of having a catheter. The reason for that is that the cuff does put pressure on the urethra, which is fine as long as there's nothing in the urethra. Once there's something in the urethra, you have that added pressure, and it's essentially adding to the ischemic time or reducing blood flow to the urethra in that specific area of the cuff, and that can lead to breakdown of the urethral mucosa. And it doesn't take very long for ischemic damage to happen. We can, see that within half an hour to an hour in some cases, but certainly after 4 hours of ischemic pressure in a sphincter that hasn't been deflated, I've seen erosions, and that leads to a whole mess of problems, including having to remove it. So those are the kind of things that we have to worry about, but that's really patient education after the fact to tell them what to troubleshoot for. So the question is, how do we manage and how do we address patients who've had multiple modalities? In the case of the patient asking the question, combination of both radiation and then subsequently cryotherapy, which is freezing of the prostate. Those are two particularly damaging technologies designed to kill the prostate, essentially, but in the process, it kills the prostate and everything around it. And so it is not uncommon for patients to have a variety of urinary complaints, especially incontinence after that double whammy. One of the important things to look for in this kind of a situation is the bladder hyperactive as a result of the radiation? We sometimes see that radiation, because you can't only and exclusively radiate the prostate, the bladder gets radiated at the same time to a degree. And when that happens, the bladder loses some of its elasticity, some of its ability to stretch. So that has to be looked into to make sure that the bladder is actually able to stretch properly. And that stretchability is compromised. You tend to have too much pressure in the bladder, and it will force leakage as a result of that. So that's correctable to some degree with medication. Similarly, the extreme damage that happens when you combine both radiation and cryotherapy to the channel of the urinary tract, where the urinary tract goes through the prostate. If you think of the prostate as a donut, the hole in the middle of the donut is the urethra that you're urinating through, and the donut itself is the prostate. Well, in this case, the prostate has been melted and frozen and radiated, and it's damaged. Well, it's impossible for the hole in the middle not to also be damaged. And what we sometimes see is that channel, instead of being open and you're leaking because it's open, it actually can be very scarred down, and you may be having what's called overflow incontinence, which we talked about earlier, where the bladder actually can't empty properly because it's so scarred down, and it's full and trickling out as a result of that. So there are a variety of issues that come into play with the combination therapies that you were talking about earlier. And so that's a situation where every individual has to be individually worked up with the appropriate tests, looking into the bladder, doing urodynamic testing to monitor the pressures, ultrasound sometimes, and addressing each of the components to try and optimize the anatomy so that you can both urinate properly and hold it properly. So the question is, are diaper products covered by insurance? And in my experience, the answer to that is no. Medications are covered. Catheters are covered. But I've not seen absorbent products covered. It wouldn't surprise me if some insurances do, but the majority of the ones that I've seen have not covered that. So the question is frequency of urination and incomplete emptying. How do we manage that, and how does that relate to what we've been talking about? The urinary system, as I said earlier, has two functions, storage and emptying, and that's all that it does. So when a patient complains of frequency or urgency, that can be one of the two, but it's not guaranteed as to which one it is. So if a patient has had some kind of surgery that would lead to scarring, we have a high index of suspicion that scarring is the underlying source of the problem, and the mechanism by which that's causing the problem is the bladder is not able to empty fully. So you're getting a degree of urgency incontinence because the bladder is actually full and the receptors are telling the brain that it has to go because it's full. And so you'll get contractions of the bladder that you can't, or the patient can't, suppress because the bladder is so full. The other factor is that as the bladder gets full, as we talked about, then the pressure builds up and you get overflow incontinence in that situation. So again, those are the kind of situations where we have to individualize our management because there's not a universal answer to that question. But if you attack each of the individual components of the problem, so if there's a narrowing, open up the narrowing. If there's a degree of bladder instability, address that with medication. So gradually you can whittle away at the factors that are causing the problem and at least get improvement. Not always possible to get complete resolution in those cases because they can be very tricky, and dealing with scar tissue is an extremely, extremely difficult problem. There are cases where the scar tissue is such a major problem that you need specialized surgery to remove the scarring and place flaps of vascularized tissue where the urethra used to be and essentially reconstruct the urethra. It's big surgery, but for patients who are debilitated by the symptoms relating to the scarring, it's worth it. So again, it becomes very individualized in that kind of a situation. So the new tissue, so the question was, where does one get new tissue for management of a scar in the urethra? There are certain surgical principles that allow us to harvest grafts and flaps from different parts of the anatomy. The most common graft area is actually the lining of the inner part of the cheek. That tissue inside the mouth, called buccal mucosa, is remarkably similar and handles remarkably similar to normal urethral tissue. But you need to have a way of getting blood supply to it, because if you can't get blood supply to it, then like any tissue that doesn't have blood supply, ultimately it dies. So the flap can be from a variety of surrounding tissues, usually the scrotal skin, because that can be sort of peeled away into two with a blood supply. And there's other surgical techniques that do similar concepts, essentially. There are relatively few urologists who do that ultra-specialized kind of urethral surgery. There's only 2 or 3 in this whole part of the state that will do that. The question relates to pelvic floor exercises and how they can impact surgical results, both by doing them before and or after surgery. So I advise my own patients to begin exercising the pelvic muscles well in advance of surgery. When we make the diagnosis of prostate cancer, we try to advise them to start the exercises. They're typically known as Kegel exercises. Women who've gone through pregnancy know these all too well, but essentially what is involved is contracting the muscle that would normally stop the flow of urine. And you don't do it while you're urinating. You might do it while you're urinating the first time just to identify the muscle. But once you've got to memorize what it feels like to contract that muscle, you squeeze it tight for 5 seconds, relax it for 5 seconds, and repeat that 5 times. And it's remarkably difficult to do, and it takes a lot of practice to be able to hold that muscle tight for 5 seconds. But if a patient will exercise that for 2 or 3 or 4 weeks leading up to their surgery, by the time they get to their surgery, they are actually able to hold the muscle at full tightness for 5 seconds. When a patient can do that, their muscle is strong enough. And all that's required subsequently, assuming that the surgery goes according to plan and the surgeon is able to do a good job at protecting the muscle, is to resume those exercises the moment the catheter gets removed. And the catheter typically stays in for 1 week after the prostate surgery, and as soon as it's removed, the patient will start exercising again. And it's really no different than exercising any other skeletal muscle in the body. If you were to do arm curls every day, 5 times a day for 2 months, you'd have a very strong arm. If you stop for a week or two, the arm would still maintain the potential to be very strong. You just have to build back up to what you were doing before you took a break. So in this particular case, the muscle can be ramped up to the way it was preoperatively very quickly. And so those patients actually notice an improvement quicker than patients who weren't up to speed prior to surgery. We also recommend for patients to do these exercises universally after the catheter is removed, whether they had started them before surgery or not. Kegel exercises do work. They can't overcome major muscle damage, but they can overcome minor muscle damage, and they can overcome the healing or the time period of healing where there's a weakness of the muscle, but the muscle ultimately recoups its normal function. So it will speed up recovery of urinary control and maintenance of urinary control if they're done religiously. For patients who do have muscle damage, they will work to improve urinary control. We often send patients for specialized physiotherapy treatment to isolate this particular muscle group, so it's kind of like Kegel exercises on steroids, done with external monitoring to actually visually demonstrate how strong the muscle is contracting. So this is a way of getting feedback as to whether you're doing the right thing and whether you're showing improvement. For patients who do that, they will notice a significant improvement. It may not cure them. And the only downside of the Kegel exercises is that if they are required to get the muscle up to speed and maintain urinary control, they're often required as a lifelong habit. So no different than working out. When you stop working out, the muscles get weaker. If you continue to work out, it's very easy to maintain their degree of tone and strength with a much less effort than waiting for them to get weak and then trying to get them strong again. So Kegel exercises for patients who need them, which is most, have to be done as a continual thing, as a lifelong training program. So the question is, are there specific bladder exercises to improve urinary control? Again, the answer to that question is tricky because it depends on what the problem is. So if the problem is that the bladder can't actually hold enough, and so it's the reservoir that's not doing its job of storing, then a combination of behavioral modification, bladder retraining, and medicine will work to improve symptoms. So I'll give you an example. Patient says that they can go for 4 hours with no problem, but when they got to go, and they often don't make it to the bathroom in time. So if you work a patient like that up, it's pretty typical that they get to a full bladder capacity, and when they get full, then their bladder just contracts. The brain has lost to a degree its ability to suppress the reflex. So we learn that as an infant when we're potty trained to suppress the natural reflex. to a degree, some patients lose that for a variety of reasons as we get older or after surgery. Now, you can do behavioral modification to adjust that. And the simple answer is, instead of waiting 4 hours, you go by the clock. So every 3 hours, when the hour hand hits one of the quarters, 12, 3, 6, and 9, you go to the bathroom even though you don't feel like you have to. Why does that work? Simple physics. The bladder never gets full enough to actually be triggered to contract. You're not actually solving the problem. Well, you're not curing the problem, but you're solving the problem by a simple behavioral modification. Unfortunately, we don't actually have a specific exercise that strengthens the muscle. We don't have it, and we don't have a medicine that does that either. We have medicines that will weaken the muscle and relieve the spasms and the unwanted contractions, but we don't have the opposite that has any real value. So the question is, does dietary intake of different kinds of fluids have an impact, either positive or negative, on the bladder function? The general rule of thumb is this: what goes in must come out. The more you drink, the more you're going to have to urinate. So every doctor in the world tells their patients, drink, 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 got to drink lots of fluids. So all of our patients drink, 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 and the result is that they have to pee, pee, pee. So that's just part of general medical culture, is that we train ourselves and we train patients to stay hydrated, which in general is part of good health. The answer to your question, though, is yes, certain fluids or certain types of fluids will have more or less of an effect on the need to urinate than others. So as an example, caffeinated products will sensitize the bladder, make those nerve endings tell the brain that you have to urinate much quicker than certain other kinds of fluids. If you just drank the same amount of water, you wouldn't necessarily have the same degree of urgency that you have. The speed at which you take your fluid in, and in other words, the speed at which you make urine, will have a huge impact on how much urgency you have. The body is very good at noticing change. When things happen quickly, the body's very good at picking it up. So if you take your finger and you press it on your skin very, very slowly, you can, spend a few minutes building up quite a lot of pressure that really won't bother you very much at all. And I can sit here and keep pushing harder and harder and harder, but just do it very slowly, and I won't feel pain. I can take the same amount of pressure with a flick, and it hurts. So if I were to flick you on your ear versus slowly push on your ear over 5 minutes to the same degree of pressure in the end, you might not even notice that I'm touching you. So the bladder is the same way. If the bladder fills up very quickly, your brain is going to notice it, and you're going to have to urinate. So if you can fill up and drink over an extended period of time, so when you see people carrying around a water bottle and they're sipping, they're actually going to probably have the urge to go less often than someone who takes a 20-ounce Gatorade and just chugs it down, or takes a pot of coffee and drinks that all in one setting. So I don't know if that answers your question, but the types of fluids that you drink and the volume that you drink will absolutely affect your need to urinate and the urgency with which you have to urinate. Like I said before, what goes in must come out. So if you put it in before 6 p.m. because then you'll pee it out before 10 p.m. And thank you for your time.